So our next speaker is Dr. Elliot Krane. He is a pediatrician and anesthesiologist who is the chief of pain management at Stanford. Thank you, Dr. Krane. Thank you.
Well, thank you for the opportunity to be here and to address this audience. I want to start by saying that in the world of pediatric surgery, pediatric surgeons and allied specialists, orthopedic surgeons, urologists, et cetera, prescribe a small minority of the outpatient opioids that go to children. So the impact that guidelines of this sort that are being contemplated today will have on opioid prescribing in children will be small. The state of Washington survey showed that 50% of prescribed opioids were prescribed by dentists and oral surgeons. The second largest prescribing group were emergency room physicians, and the third orthopedic surgeons. And many of those orthopedic surgeons were prescribing not for surgical indications, but for treating fractures and sprains that they saw in their office. So if you look at the number of prescribed opioids in children post-operatively, it represents probably about 15% of the number of doses that are prescribed globally. Secondly, it should, I hope, be a source of solace to some that the frequency or incidence of opioid abuse and misuse in children is no larger today, in spite of what's going on nationally in this country, than it was in the 1970s and the 1980s. The Monitoring the Future study is an annual review that comes from the state of Colorado, and it has been in effect for about 20 years. And in the Monitoring the Future study, junior high school and high school students are interviewed anonymously and reveal things about their lives, such as the frequency of alcohol abuse, cannabis use, tobacco use, and both prescribed and non-prescribed drug use. And it's reassuring to me as a pediatrician to know that while there was an increase in frequency in the late 1980s and 1990s, which was quite a bit societal, it is now today no more frequent, with the exception of cannabis use in certain states that have legalized cannabis, than it was in the late 60s and the early 70s, at which time it wasn't perceived to be a problem. And indeed, it's not a significant problem today. What we don't know, but there's no evidence to suggest this is true, is that opioid prescription or administration to children in their childhood years or adolescent years increases the risk of opioid misuse or abuse, and more specifically to opioid use disorder in adult years. So there's no significant evidence that shows that that's true, and that is a concern, but we don't have any support for that concern at this time. Now, a few caveats before I show you a list. One is the list obviously cannot be comprehensive. I've categorized the list in terms of body area. You've heard about different options for categorizing the list. Not every patient, as you've seen, requires opioids, even after major surgery. For example, there are important pharmacogenomic differences. Where I practice, we have a fairly large Pacific Islander population, individuals from Fiji, the Hawaiian Islands, it's Samoa, American Samoa, etc. And those individuals have remarkably high pain tolerance and low opioid requirements. And I've seen individuals after major abdominal surgery who have required in the hospital postoperatively no opioids whatsoever. Conversely, we know that, and we've always joked that redheads have a very high analgesic requirement. And in fact, it turns out, in spite of the jokes that we would make about this, that there's an important pharmacogenomic reason why that's so. So that one prescription, a recommendation or a treatment guideline is not going to fit the entire population. So some will require opioids and some will not. And this list is called from a survey that I did of my colleagues nationally, as well as colleagues both in the surgical specialties and world of anesthesiology and pain management at Stanford. Now, I do want to emphasize that we all agree that anything that we can do to spare opioid prescriptions is good. I'm not so concerned about opioid use disorder in children. I'm concerned about side effects and toxicity of opioids, and that's why I would like to limit their use. There's a whole number of different modalities that are now in common use, including the preoperative and intraoperative use of different substances that you see listed on this slide, the use of peripheral nerve blocks and peripheral nerve infusions postoperatively, intraspinal administration of analgesics and local anesthetics before or during surgery, and the postoperative use of adjuvant drugs, including gabapentinoids. All of these things will reduce opioid requirements. And in addition to that, it's important to realize that anesthesiologists do not only have the power to reduce postoperative opioid requirements in the hospital and after discharge home, but we actually have the power to increase their necessity. For example, the infusion of remifentanil, which is a synthetic short-acting opioid, which is not uncommonly used for surgical anesthesia, actually produces postoperative opioid-induced hyperalgesia, will induce increased analgesic requirements postoperatively and not decreased opioid requirements. So my list is basically one of anatomical area. I think there's wide agreement that open chest surgery and chest wall repairs, open abdominal surgery, and included in this are open pelvic operations done by urologists. We don't have prostate resections in children, but we have a lot of bladder reconstructions. Orthopedic long bone surgery, spine surgery, and pelvic surgery are very, very painful. And some, but not all, neurosurgical procedures are associated with not only the use of, and this applies to this list and as well, not only the use of postoperative opioids in the hospital, but opioids that follow the children home. And the length of time is highly, highly variable. It depends quite a lot on what Dr. Brown told us from Phoenix. It depends quite a lot on socioeconomic variables. As I said, it depends on pharmacogenomic variables. One of my colleagues at Stanford, who does basic pain research, did a huge data analysis of what variables are associated with long-term opioid use in adults after knee replacement, knee arthroplasty. He analyzed hundreds and hundreds of genomic and other variables. And what he found was that over 50% of the variability between patients could be linked to a specific genotype that's associated with an inflammatory process. So that highlights he was looking at who is still using opioids a month later versus who was not using opioids a month postoperatively. So there's a very important pharmacogenomic variability that nobody so far has discussed, but is a reality in fact. So that concludes my comments, and again, I look forward to the discussion and your questions. Thank you.